Good evening, everyone. My name is Charmaine Bukovets. I'm the Executive Officer of Thoroughbred Breeders Victoria, and I'd like to welcome you all and thank you for Zooming in this evening. I know how busy everyone is currently on our farms, and I really do appreciate you giving your time up today after such long days. I trust everyone is sitting back comfortably with notepads ready for today's webinar session. We have obviously some great topics lined up from three speakers from Avenel Equine, who are great partners of TBV and have been for some time. These webinars, I must thank firstly a few people, as they would not be possible without them. We have been running these webinars now since the 10th of August, and we are running them through to the 25th of August. So this year, a key message throughout the industry has been about collaboration and working together. Each year, breeders associations across Australia host a range of webinars, and each association has teamed up this year to share the topics that we would normally offer to our members across the country. This is to cover updates, important information for our participants and our members. So this year, TBV been working closely with Hunter Thoroughbreds New South Wales, AgriFutures, Charlesworth University and other organisations to bring you a wide range and diverse portfolio of information. Tonight, we will go through a few topics. Victoria graduated from the Royal Veterinary College, London in 2013. In 2014, Victoria undertook a rotating internship in anaesthesia, orthopaedics and internal medicine at Rainbow Equine Hospital in the UK. Victoria's clinical interests include equine reproduction, neonatology and gastrointestinal disease. Alongside clinical practice commitments, Victoria is a registered racecourse veterinary surgeon and FEI registered treating veterinarian. Victoria is also a published author in the prominent journal Equine Veterinary Education. And Victoria first came to Avenel Equine Hospital in 2020 as a seasonal associate veterinarian and has returned to Avenel Equine in 2021 in a permanent role as associate veterinarian. So I'd like to welcome Victoria to, I guess, our virtual stage tonight and pop on screen to share her presentation about infertility in the broodmare endometriosis. How are you tonight, Victoria?
Good, thank you.
Thank you for joining us. It's greatly appreciated after such a long day out in the field, and we're very excited to have you talk tonight.
Hello, everyone. So I was originally asked to do a presentation on mare subfertility, and thinking about that topic just made me realise what a massive topic that really was, and how really this talk needed. I decided to go with something that's super common, endometritis, and something that I think anybody that works on horse farms or with broodmares will be very familiar with. It's a massive topic in itself, so we're just going to do a bit of a whistle-stop tour and go through the sort of causes, how you identify it, and just a couple of the potential treatment options. So what is endometritis? The definition really is inflammation or infection of the inner lining of the uterus, and really it's probably the dominant cause of subfertility. Certainly represents anything up to 60% of the diagnosis in barren mares, and many studies will show far greater percentages in terms of the underlying cause. It's important to differentiate from metritis. So metritis is a condition that we often see associated with retained fetal membranes. Endometritis doesn't have any external clinical signs of disease, so when you look at the mare, there's nothing untoward in physical examinations that you could detect, whereas metritis does cause ill health and is of a serious sort of overall medical concern. So how does endometritis start? And there's lots of different potential mechanisms, but really we need to consider it as a normal response to breeding. So this diagram shows how breeding itself can stimulate an inflammatory response in all mares, but obviously in the majority of mares, this inflammatory response is cleared successfully and the inflammation subsides. In mares that are either susceptible to endometritis or have pre-existing or compounding factors exacerbating the condition, there's an inability or failure to clear inflammatory products, and then continued and increased inflammation, which can lead to persistent endometritis. And secondary infections can then result. You can get altered immune responses, and if the uterus remains inflamed for some time, we can get degeneration, which is obviously a concern for future breeding. So other mechanisms, and really we're talking about non-infectious endometritis, which means not caused by either bacteria or fungi or yeast, and infectious endometritis, whereby we have a pre-existing infection with usually bacteria in probably 60% of cases, and less commonly fungal in around sort of maybe 1 to 2% of barren mares. With regards to the non-infectious, we've got urine, post-mating, as we've already discussed, and air. And the presence of anything in the uterus really can stimulate inflammation. And so external anatomical abnormalities are key to reducing the risk of endometritis developing. And when we talk about external anatomical abnormalities, we're talking about mares with a very sloping vagina, either a poor vulval seal or a propensity to pool urine. Provides the barrier from the vagina and vestibule to the uterus. And so if we've got abnormal cervical function, we can get reduced uterine clearance, which means that potentially fluid can't evacuate the uterus, which means it can become colonized by bacteria. Or direct sort of primary cervical problems where we have tears, again breaching the barrier from the vulva, vagina to the uterus, but sometimes also cervical abscesses, which can directly seed the uterus and set up endometritis. So other risk factors, poor uterine clearance, and often in older mares that have had lots of foals, the uterus can sit very low down in the abdomen, which means that gravity is not on our side in terms of fluid being able to evacuate. But mares that have foaling complications, dystocias, are much more prone to having this condition when they come around to be bred thereafter. And you can see this mare has a lot of vaginal hematoma, swelling. It's a risk factor for endometritis. If we have retained fetal membranes, inevitably there'll be inflammation that sets up in the uterus. And if this isn't managed swiftly, that can then progress to secondary infections and more chronic changes. Multiple breedings at mating has increased risk for endometritis. Obviously, most mares will clear that normal post-breeding inflammation quite swiftly within about 72 hours. But in a subset of mares that are at risk of this condition, multiple breedings on the same heat is associated with more persistent inflammation, which isn't always readily cleared. And if it's not treated, can progress to subfertility and reduce pregnancy rates. Breeding hygiene is important for reducing the likelihood of this condition developing. And that doesn't just mean in the covering shed, but also any time that we're entering the vagina to do treatments, uterine swabs, even repairing caslix, we need to consider cleanliness, the need for tail bandages and cleaning as utmost priority. So why is it actually a problem to have an inflamed uterine lining? Obviously, if you've got inflammation, you're not normal, and we want this environment to be as normal as possible for it to host a pregnancy. But there's a little bit more to it than that. The presence of inflammation itself will result in fluid and inflammatory products, which create a hostile environment for any newly fertilized embryo. So a newly fertilized egg will arrive to the uterus around about day 6. And if the uterus isn't in good shape when that happens, then we're not going to provide the optimal conditions for its survival. If the uterine wall is inflamed, we might not get recognition of that early pregnancy, but also we can have the production of uterine prostaglandins, so PG, that we use to bring our mares back into season. The uterus itself, when it's inflamed, will produce this hormone, which can lead to early breakdown of the CL, short cycling, and potentially pregnancy loss. So how can we detect endometritis? And fortunately, in most cases, it's readily detectable on reproductive ultrasound examinations, combined also with routine swabbing techniques. So generally speaking, we're talking about mares that have fluid and or uterine wall changes or excessive edema patterns. And that can be both when they're in season or in the interovulatory period. Sometimes mares will have very pronounced fluid production post-mating, but other times this can be much more subtle. And in some cases of endometritis, there won't be anything untoward to see at all. So we're combining our routine ultrasound examinations with swabbing techniques. And swabbing is done for the purposes of cytology, the microscopic study of cells, but also for the purposes of culturing, which we'll come on to. So cytology is collecting cells from the lining of the uterus and then examining them under a microscope to look for characteristic changes that we associate with inflammation. So on the left, you've got normal epithelial cells, so normal surface lining cells of the uterus, and these are all sort of stacked together and we can't see any inflammatory cells. And then on the right, you've got cells called neutrophils, which are involved in the sort of management of infections and inflammation in the body. And if there's inflammation in the uterus, these cells will migrate to that site and be detectable usually on your sample. And those can be detected using swabs or cytology brushes, but also collection of low volume lavage fluids, which are then sort of spun down and examined in the same way, or much more comprehensively by uterine biopsy. And lastly, bacterial culture. So again, we're sort of obtaining bacterial cultures on our routine swabbing techniques. And these will be processed both for general screening on blood agar is pretty typical. So this is E. coli growing which is one of the commonly isolated bugs in the mare uterus. And the bottom right, this is chromogenic agar, which is a special type of agar which has colour changes which differentiate different bacterial types. But often it's a bit of a minefield, and we suspect endometritis is there, but we can't actually find it. So we might not be able to culture bugs, and we might not have inflammatory cells on our swabs. And that probably accounts for a minority of cases, but there'll certainly be barren mares where we've got pretty little to go on. And in terms of looking for a gold standard diagnosis, then probably biopsy is the way forward. So that's actually taking a tissue sample from the surface of the uterus, sending it away for histology and in-depth microscopic analysis. So that will give us an idea of the cell types present, but also whether or not there are any latent bacteria in the different layers of the uterus. And we can also grade these biopsies to give us a prognosis for breeding based on certain characteristics like the degree of uterine fibrosis, for example. So how do we treat endometritis? And it's a very multi-layered approach, which has to be tailored to each individual mare, and it's really kind of beyond the scope of this lecture. So I'm just going to pick a couple, and hopefully that will shed some light at least on part of the approach. So treating infections. Infections probably account for at least 60% of the cases of endometritis. So that means that, you know, in mares that are presented, probably over half of them have an infection. Whether or not it can be cultured or not, whether or not it's identified on biopsy, will depend. So a bacterial component is likely, but really we need to be quite mindful about our strategy, therefore, as to how to treat them. We need to know which bug, if possible, and therefore try and treat them specifically with antibiotics that we know will be effective. And this is important ever increasingly, especially with growing concerns about antibiotic resistance. So in 2020, the World Health Organization declared an emergency state and stated antibacterial resistance was one of the predominant threats to global health and food production, but also just development in general. And so whilst we've got to accept that probably bacteria account for a lot of our problems in mares, we need to be quite clever about how we use antibiotics and take into consideration the different bacterial traits in our treatment strategies. And that sort of brings me on to the next aspect, which is managing biofilm. So biofilm is a sort of relatively new concept. It's described as an accumulation of bacteria and bacteria-derived substances protected within a sticky organic matrix that can adhere to surfaces. So it's not something we can see, but effectively it's a product of some bacterial populations. And the main issue with it is that it can be incredibly long-lasting, but it also protects the bacteria somewhat, both from the body's own immune system, but also from medications such as antibiotics that we use to get rid of bacteria. And bacteria can be up to 10 to 1,000 times more resistant to antibiotics when they're within a biofilm itself. They're also protected, as I said, from the host immune system, which means that the mare's normal ability to fight infection is reduced. And it can also make it harder to actually physically grow bacteria. So we might assume that they're not there based on the back of negative multiple cultures, but also because they're not stimulating an inflammatory response, we might not pick up any changes on our cytology. So how can we manage this problem? And really there are two aspects. The first is actually physically disrupting the biofilm and breaking it down. And then the second aspect is to kill the bacteria. And some of the agents we use against biofilm will achieve both these things simultaneously, but some don't. And that's where identifying specific bacteria is important, because different bacteria respond differently to each of these agents. So getting a diagnosis rather than treating blind is always the best way forward, but obviously we've got to be mindful that that's not always practically possible. So some of the known biofilm producing bacteria include E. coli, which is one of the predominant cultures that we'll find in endometritis. And if you look at different studies, you'll get different prevalence rates of that bug in terms of actually causing endometritis. But broadly speaking, we could say that maybe up to 25% of all cultures might be E. coli. And so if you consider that perhaps up to 25% of endometritis cases could be biofilm producing bacteria, or more if you consider that there are others, for example, strep, then we need to think about this as something we should be really doing as part of our clinical practice in treating endometritis, one of the most common causes of subfertility. One of the other great things about a lot of these agents is that they can actually reduce antibiotics. And if when we're treating bacteria, we're treating them more effectively, we therefore can use less. And in consideration of what we mentioned earlier about prevalence of bacterial resistance, this can only be a good thing. And the last aspect I'm going to talk about is removing inflammatory products. So removing inflammatory products and dealing with fluid has got to be probably top 1 or 2 emerging endometritis as a condition. And generally this is achieved with uterine lavage, so that's physically flushing the mare. So we generally will use 1 or sometimes 2 litres of sterile fluid infused through the cervix into the uterus and then directly siphoned back out. And this is done to remove physical debris, but also to dilute out bacteria. And this process can be repeated over and over until we're sort of satisfied that the level of contamination is reduced. And this is combined with drugs to promote uterine clearance, so oxytocin, sometimes dilating the cervix just to actually make the passage, and kind of forgotten is exercise. Promote natural uterine clearance. And uterine lavage can be done as part of your general treatment approach. So, for example, if you're treating biofilm, I would often then flush them afterwards, because I think often if you're using a product to destabilize biofilm, you'll get a lot of debris coming away. So I'll use it as part of that treatment, but also pre and post covering, just to provide an optimum environment for the sperm, but also to remove those contaminants after breeding. So as a summary, endometritis is a naturally occurring response in all mares to breeding, but in normal mares, this will usually be cleared naturally by about 72 hours. But persistent endometritis is the most common cause of infertility. And the diagnosis in most cases will be on ultrasound and swab. And I've put most because I think we'll all be familiar with cases that really have no indicator of any underlying issue. And, you know, we'll use common treatments for endometritis and have breeding success. Perineal conformation is probably the greatest risk factor. So cas-licking mares and reducing any risk of contamination into the vestibule is probably the best way to prevent this from happening. And if it does occur, we have to be prepared for multi-layered treatments targeted to each individual for the best outcome.
And if anyone has any questions that we haven't captured here, we'll get them answered for them. Angus graduated from the University of Melbourne in 1989. He worked in racetrack practice at Flemington for 3 years before moving to Murdoch University in WA as a resident in equine medicine and surgery. Angus gained membership of the Australian and New Zealand College of Veterinary Scientists in equine surgery in 1995 and fellowship of the ANZCVS in 2002, allowing him to be registered as a specialist in equine surgery. Angus joined the Scone Equine Hospital in 1997, and his work involves surgery, radiology, conformation and lameness evaluation and stud, performance and pleasure horses. His surgical interests include fracture repair, arthroscopy, laparoscopy, and all orthopaedic procedures. Angus is currently one of 2 nominated veterinarians in Australia who assess the suitability of thoroughbred racehorses for export to Hong Kong. He's a member of the EVA's Education Subcommittee, a keen publisher of scientific articles in veterinary journals, and passionate mentor of interns and young veterinarians. He's presented over 80 lectures at veterinary conferences around the world, and he is a past treasurer of the EVA, past chairman and member of the Credential Committee of the Equine chapter of the ANZCVS, and a previous examiner for membership and fellowship of the ANZCVS. I present to Angus, who will be chatting to us about infertility in the broodmare around Oviduct surgery. Take it away, Angus.
Thank you very much, Charlemagne, and thanks everyone for spending some time to watch this tonight or maybe in the future. I will say that we are very pleased to have the calibre of Victoria coming back to Avenel this year. We have 8 veterinarians in Avenel this year, and we're really trying to develop this practice, and she's a really important pivotal member as the other 7 are as well. So thanks, Victoria. I will also say New South Wales number plates, I'm sort of got a target on my head, but rest assured I'm fully vaccinated and I've had more COVID tests than you care to imagine. It may also seem a little strange for a surgeon to talk about infertility. The reason I wanted to touch on this is it's something that I've certainly done a lot of, and it's one procedure that as a surgeon we can make a really big difference. And we do recognise within our practice that the most important thing we can do for our clients is to get their mares in foal. Everything else flows from that. If you don't get your mares in foal, then your business is going to be no good, and you don't have a product. And so we recognise that, and we see that as very important. So the disease I'm going to talk about is pretty uncommon, right? It's not a common cause of infertility, but it's an important cause. And it's one thing that you do need to recognise, and it's one thing that there are some options for treatment that have a very, very good success rate. So it's something to keep in the back of your mind. If you're really struggling to get your mare in foal, the oviduct could be the cause. And so hopefully I can explain it to you during the course of this presentation. So the oviduct, or some people will call it the uterine tube, really is the thin tube that connects the ovary to the uterus. And if you see on this image here, this is the ovary here. So this is a laparoscopic view, right? This is looking in from the horse's flank. This is the ovary. This is the course of the oviduct as it comes up the ovary, along and around, and then it drops down into here, into the uterus. This is the tip of the uterine horn, okay? So this is the normal course of the oocyte, or the egg, as it's released from the follicle. It comes up this area and it slowly moves through here into the uterus. Now, the oviduct has a number of functions. One, it allows that movement of the oocyte, but also allows sperm to come the other way. Okay, so sperm obviously will come this way, and that they will meet somewhere along that tube. And the oviduct provides an environment where that fertilization can take place, and also supports the development of that embryo for the first 5 days. And after 5 days is when it moves into the uterus, right? Now, we know that the movement into the uterus is triggered by release of prostaglandin from the embryo. And look, I'm telling you some science stuff that you'll probably forget, but this is an important reason why we use certain drugs. And I know you've all heard of different types of prostaglandins. The one we use in this particular surgery I'm going to describe is slightly different to the common ones that you probably understand. So, as I said, there's been a lot of work done on what these prostaglandins do. I'm not going to bore you with this slide, but we essentially know that the prostaglandin that we use in this surgery does two things. One, it causes some contraction of the oviduct, and so it pushes the contents of the oviduct along the tube into the uterus. And obviously, if it's a fertilized embryo, then that's exactly what you want it to do. Occasionally, there's other things that cause problems, and it pushes them in as well. Right at the end of the oviduct, before you get into the uterus, there is a tight valve, essentially. It's got a pillar, and that has got to open to essentially to release that fertilized embryo into the uterus. And the prostaglandin aids to actually open that valve as well. So the topic of the presentation was oviduct blockage. And so what causes blockages? The most common thing that causes these is where you get this accumulation of this sort of gelatinous tissue. So at ovulation, there's not only an oocyte release, but there's all this protein-rich fluid, and you've all seen it on ultrasound. And that protein sort of almost congeals, and it forms these sort of gelatinous masses that can sit within the oviduct, and it can actually block the oviduct. And it can block the movement of both that gelatinized tissue, and future eggs that are coming down the oviduct as well, and it causes a non-permanent blockage. And what I mean by that is that can be cleared. Right? That's just like your toilet being blocked up. We can clear it pretty happily with certain techniques. In other species, we know that the blockages that occur tend to be more permanent, especially in women and cattle, and so it's a much harder thing to try and treat. But luckily in the horse, they tend to be able to be cleared. We identified some other causes as we've gone through doing about 200 surgical procedures on mares. And we reported in the literature a few years ago these restrictive bands, and I'm going to show you some of these in my talk in a minute. And we started cutting these bands, and we did perceive that we got a better success doing that. And I'll show you some of those. Very occasionally, I'll look into a mare and I'll see this chronic scarring. And this is an image here. This is the oviduct here. That's just a bit of gut. But we can see this chronic scarring here. Now, I don't know what causes this. I've really got no idea. But certainly some mares, I will look into them and I'll go, you know what? This oviduct is so scarred, I don't think these mares will ever get involved. Now, that's a really big call, isn't it? But occasionally you will look inside them and you go, you know what? I think you're really wasting your time here. I suspect those mares end up on an online auction. And so it can be useful for that. There are some other abnormalities that we can get associated with the oviduct, and that's at the fossa, which is where the follicle will sort of rupture into and release the oocyte. They're relatively uncommon, but certainly that's a possibility. So how do we diagnose this cause? And people have tried all sorts of ways to try and diagnose it. I think the bottom line is it's very hard to diagnose. And people have tried these. I'm not going to bore you with all these different options, but people have been trying to do this for a long time. Walter Zent, American from Haggard's, 1993, first published his anaesthetizing the mares, trying to flush through them. A little bit too invasive for what we're trying to do. People put starch granules to see if they'll go down through the oviduct. It's really unreliable. It's invasive. Often in women, they will use a dye that's either placed onto the ovary or into the uterus and see if it'll go one way or the other. Again, it's unreliable. It's invasive. One thing that we sometimes do in the off season is we'll try and flush an embryo. So you'll breed the mare and you'll try and flush an embryo to see if she can actually produce an embryo. And that's, you know, that's better, isn't it? It's something that we do commonly. You will get some false negatives, of course, because even if they do produce an embryo, sometimes they'll die before you can collect them, or you have trouble collecting them. But it's something you can do. You're not going to do that, obviously, in the stud season, because you're not going to give up a cycle, I suspect. So how do we diagnose them? And the first way is that we've ruled out everything else, right? And these are the common things, and I won't go through them all, but it's important that you do rule them out if this is the way that you're trying to diagnose this condition. And Victoria's touched on this, and sometimes some of these are hard to rule out. It is hard to rule out if they've got endometritis sometimes, there's no doubt. What's more common is that we go, you know what? I know this mare's got a few issues, but I still think she should have gone in foal. I still think that we're managing her endometritis. I still think we're managing a busy stallion. I still think that the uterus is okay, cervix is okay, and I really think this mare should have gone in foal, and I'm looking for something else. Now, you don't jump to this conclusion because the oviduct is not a common cause, but certainly if you've really worked the mare up and you've gone to the lengths of trying other things, then the oviduct is absolutely a possibility, and it's something that you could tentatively diagnose. So at that point, what do you do? And I've sort of tried to break this up. And I've tried to break the three options into doing nothing, a strip, or a bridge, and try and make an analogy in that regard. So the first is that I'm sure some mares will have these temporary blockages of the oviduct, and then in time they clear themselves. Now, there's no way of proving that, but surely Mother Nature's got to have taken care of some of them. I'm sure that's the case. I think it depends on how patient you want to be in the stud industry, to waiting to see if things improve or not. And of course, when the season hits, no one's patient, because they'll realise the importance of getting a mare in foal. The second is the application of misoprostol, which is a type of prostaglandin. And I'm going to talk about that option in a minute. And that's an option that's become available and more commonly used in the last few years. And I talked to Victoria about this, and I know she's done a number. And it's certainly an option that would appear to have some merit, and we'll talk about that in a minute. And the third option is the laparoscopy, which is really the procedure that we've been doing in Scone now for about 12 years. And I think that is an option. It's the gold standard, is that one, it's got good reported success rate, and two, it helps to diagnose. And that's important to try and guide treatment and guide whether you want to keep going with these mares or what you're going to do with them. So I'm not going to talk about time because that's pretty obvious, but the second is this application of misoprostol. And what they do is you get these tablets of misoprostol, which is a prostaglandin E1, and you reconstitute that into a liquid. And then it's placed deep within the uterus with this special tube. It's an inseminating tube, and it's placed right near the little propeller, which is the valve where the oviduct comes into the uterus. And the theory is that you're close to the oviduct, and hopefully then that drug will be absorbed in that general area and have some effect on the oviduct to contract along the duct and to open the valve. Okay, we don't know it's getting there, but the theory is it's close, and is close good enough. The success rate of these 22 cases that were published is pretty good. And you've gone from 0, remember, these are mares that have not gone in foal for generally a year or two, to 68%. We know that on the first cycle in this paper, about 45% got in foal on the first cycle. Now, the assumption that we've made, of course, is that these 22 mares did have oviduct blockages, and that's why some of these papers, you've got to be careful reading too much in. And it's the same with the laparoscopy papers. We've got to make sure the researchers really did choose the right cases to test this product on. So it's reasonably cheap, this approach. It's got reasonable success, and it's non-invasive, and that's a good thing. So in my mind, there's a role for this particular procedure. The cons are, is close enough, good enough? Is putting up prostaglandin close good enough? Well, we don't really know. We haven't established a diagnosis, which would be, it's always nice to know what you're treating. And then Victoria has told me that she's had a number of mares. It's a significant risk that if you put this product into the uterus, then you induce an inflammatory response. And so this particular technique is not going to be used whilst the mare is carrying pregnancy. So this technique would be used in the off season, or when you're going to sacrifice a cycle, or try and modify a cycle to allow this particular treatment. The technique that I have the most experience is with this is the laparoscopic technique. And so I said, we started doing this in Scone in 2008. So what's that, 13 years now. And we'll talk about our results in a minute. This particular procedure is done 4 days after ovulation. And so these mares are carrying service. We can do this in the middle of the stud season when they're carrying service. We do it at day 4 because we're hoping that it takes about a day for the prostaglandin that we put onto the oviduct to have its effect. The other thing we know is we can actually do this at any stage of the cycle. It doesn't have to be when the mare's carrying service, and I've got a couple lined up to do next week, so we can do it any time. What we find happens is most people go, they try for the first cycle or two during the stud season, and then they go, you know what, I'm running out of time, let's get this procedure done. And so we don't often do many this time of year. We tend to do them more in October, when people are starting to get a little desperate and they're not getting these mares in foal. The procedure is that the mare comes into the hospital about a day before the surgery. We get a feed reduction. We don't starve them, but we slowly debulk them. Their feed, the surgery is undertaken. It's done standing. And this is an image here of an old room that we had that we now have a new room. But the mare is standing. Obviously, this is her bottom here. She's in these special stocks that can open up very easily if something goes wrong. Excuse me. And we put the camera, the big long camera, into the horse's flank. We've already done the left side, and now we've moved around to do the right side. So you've got to do one side at a time. And this is just a close-up view here of an assistant holding the scope. This scope, when we use the scope for an arthroscope, it's about a foot long. Sorry, it's about 20 centimetres long. This scope is about half a metre long. And it's really designed to look around a large part of the abdomen, but we're really only looking at the uterus in most of the time. And then we use instruments. We have 2 or 3 holes in through the side of the flank to allow us to do what we want to do. So once we visualize the ovary and the reproductive, and the uterus and the oviduct. So, and this is the right side of the horse. This is the left side of the horse. Again, here is the uterus. Here is the course of the oviduct. And once we've identified it and we go, yep, we think we've definitely got a blockage, then we place this gel. Now the gel it's a pretty cool, it's a gel that's actually made as an intravaginal device for women to induce parturition or to induce birth. And so when it's in the fridge, in this sterile container, it's a liquid. And then when it hits body temperature, it becomes a gel and it adheres to the tissue. And so we use gravity here. We place the gel in this sort of area here as a liquid. And as it starts to warm up in this environment, it will drizzle down and then it will attach and will actually adhere very happily to the oviduct. And so we know that we've got this prostaglandin right on the duct. If we were going to place it with the previous technique, we're going to place it down in here somewhere, right? And that distance is variable depending on the mare, but it's, it could be 10 centimeters or further. And that procedure it takes, by the time we bring the mare into the crush, do on both sides, it's about an hour. And the mares are generally very tolerant if it's done in a certain manner. So I talked to you about these restrictive bands that we published out of Scone a few years ago. And here's a couple of examples. There is this band crossing the oviduct here. Again, oviduct, uterus, sorry, ovary, oviduct, uterus, restrictive band. We know that the oviduct at maximum dilation is, say, 100. So let's put a figure of 100 on it. The developing oocyte or embryo is 8, right? So there's no doubt we can have some restrictions across these bands, and you've only got it's got to. Well, I've totally lost the oviduct. Then you go, that's definitely having some effect, and it really worries me. So we started cutting these, and we use a little pair of scissors like this. This is a different horse. This is the same horse. That one, and that one are all the same horse. These horses got some bands. We cut these bands, and you can see that they sort of pull away and they remove this sort of restrictive nature of the band. And you can physically see the duct sort of dilating a bit underneath you. And then we've placed the gel, and you can see this sort of shiny stuff all around the place where the gel is adhered to the oviduct. And we've done our job. We find that I'm cutting these bands in about 30 to 40% of cases, right? Now, we were a little worried that maybe these bands were there for good reason, and that by cutting them, we may cause excessive scar tissue, and we may have caused some damage. And we were very, very mindful of that. And so we looked in a number of mares after doing these down the track, just to make sure we were doing no harm. And we were comfortable that providing we cut them in this fashion, that we did not get appropriate scarring over the oviduct, and we felt comfortable that this was an okay thing to do. So really the only way to assess your results is to critically look at them. That's very important. And so Jenna Pye, who's at the time was an intern, she's now back in Scone as a surgeon, wrote this paper up, and we found that we had an overall conception rate of 89% using this technique, which was pretty good. Well, it's excellent, isn't it, really? We found that the conception rate on the surgery cycle was 62%. So the ones we do at surgery, when they're holding cover, 2/3 of them went in foal straight away. It's an outstanding result. And then we looked at the mares the next year. We go, right, did they go in foal again, or did we cause some problems? And we found that again, that 78% went in foal the next year without any further procedure, right? We think that the laparoscopic procedure lasts for at least a couple of years. We didn't have any pregnant. So we didn't have any complications. We didn't have any pregnancy. We didn't have any complications when we did them. That was a really important thing as well. So we've now done about 200 mares where we've done laparoscopic oviduct surgery in the last 12 years, and we're still getting a pregnancy rate of about 8%. And remember, that's from 0, so that's an exceptional result. What are our complications rate? I've had one mare die. That mare did not die from a surgical mishap. That mare died because she got diarrhea 2 days after surgery. Now, we've modified the way we restrict the feeding on these mares, and we no longer use antibiotics at all. And I think that has made a big difference, because they're two factors that can really influence the mare's flora and risk of diarrhea. So I think that's made a big difference. And obviously, if you're going to do that, you need to make sure you do this in a sterile environment. These mares tolerate the procedure very well under appropriate sedation, and they're back in a paddock the next day. So they're not sitting in boxes for long periods of time. It's not where you want them to be. And we've had no surgical site infections. So the risk to the horse is very low in the right hands. And I'm not saying that I'm the only one that can do this. There's a number of people that can do this procedure. But the risk of complications is low if it's done appropriately in the right environment. So, excuse me. In summary, oviduct disease is a cause of infertility. It's not common, but it does occur, and it's something that, if you do suspect it, there are good viable options that you should pursue, because it's a whole lot cheaper pursuing them than having a mare that's barren for the year, I suspect. The options for treatment are really good. What we found in Scone when we first started doing this, people were very good fantastic result, and then we had a bit of a lull in results. And I think people said, you know what, this is a great surgery. And I would look in some mares and I go, wasted your money. And they go, yeah, we thought you might say that, but we just thought we wanted to have a look to see what was going on. And I suppose there's that, because you can say, right, well, we've ruled that out. You know, what else is going on with this particular mare? But that did influence our success rate. But I think it's now come back to the point where people go, look, let's be sure before we go into this procedure, or at least if we're not sure, we know what we're going into, because no one really likes to know that they've just spent some money on a surgery and they didn't get a pregnancy.
Now, thank you for that. That was very informative. I really enjoy that. I always enjoy these webinars and the presentations. I think they're such a great insight to the knowledge that you all have. We haven't got any questions and answers, which means you've either covered that really well, or or people are doing a few bits and pieces. So I don't have any questions. I think you did a really good job. Does anyone have any questions or answers they would like to ask at the minute?
Contact Scone or Avenel, and I'm sure we're happy to talk to them, so that's fine.
Perfect. Angus, thank you so much.
Hey.
I appreciate your time. and thank you for such an informative presentation. Katie graduated from Liverpool University in the UK in 2007. She completed an internship at Newmarket Equine Hospital before travelling to Australia to work for Scone Equine in 2009. Katie worked 4 stud seasons in Scone and Marundi, rotating back to Newmarket for the corresponding Northern Hemisphere seasons. In 2013, Katie moved to Southern Highlands Equine Centre, where she worked for 2 years before joining the team at Avenel Equine Hospital in May 2015. And Katie then became a director in 2018. Katie, you enjoy, as I have on my notes here, all aspects of equine veterinary practice, with a particular interest in reproduction and foal medicine. As well as servicing stud clients, Katie assists with the smooth running of the hospital and manages an ever-growing team of vets, nurses, and support staff. She's an accomplished diagnostician and performs a large amount of the yearling sales radiography for the practice. Katie holds graduate certificates in advanced veterinary practice and veterinary business management. And Katie, you're here to talk to us tonight about periparturient conditions in the broodmare. So I'll hand over to you.
Yeah, well, thank you very much, Charmaine, for TBV for hosting this evening again. I think it was a great success last year, and we were all delighted to be involved again. Now, last year I gave a talk on foaling and dystocia, so I thought this year I would expand a bit on what else there is to sort of watch out for in your late term and newly foaled mares. So I'll see if I can get my screen up now. Okay. So, what is the periparturient period? Well, these are your first a few days and weeks around foaling. So they're a high risk period. It's when we see a lot of genuine emergencies as vets. You've got, obviously everyone on the farms has got a lot of increased monitoring. We've got foal watch on, and yeah, everyone's keeping a very close eye on their mares and foals. Obviously, the more aware you are of the potential complications, then you'll be able to seek at the earliest possible intervention. So most mares will actually reach term and proceed through the foaling process without too many complications arising. But when things do go wrong, they require urgent veterinary attention, and they may be catastrophic despite our best efforts. So before foaling, we've got conditions that are specific to late pregnancy. So these are things where the heavy gravid uterus is the primary cause of the problem. We've also got other conditions that may be exacerbated by having that large gravid uterus putting pressure on other organs and displacing other organs within the abdomen. This tends to be causing a number of different types of colic, which I'm probably not going to go into too many details because we've got so much to cover. So obviously we all know that dystocia or difficult foaling is one of the major issues that we're watching out for. And then after foaling, we've got a lot of problems, the majority of which are associated with your traumatic foalings and dystocias. So here's just a list of some of the pregnancy-specific complications I'm going to talk about, and we're just going to go through some of these in some more detail. It's not a comprehensive list by any stretch of the imagination, but some of the things I thought were either more common or more interesting to talk about. So starting off with uterine torsion, this occurs in late pregnancy, so most often sort of 9-10 months of pregnancy up until term, and it's when the uterus actually turns on itself, so you end up with a twist in front of the cervix. So obviously the mares, it causes discomfort in the mare, and although they can be present for a few weeks, so it's usually low-grade colic symptoms. But obviously that mare is not going to be able to foal that foal if there's a twist closing the exit point. We're not really sure why it happens. There's some people think the mare rolling or vigorous fetal movements, or could be due to low fetal fluid volume. So when on diagnosis, the veterinarian can palpate the broad ligaments. So you can see on the diagram here, if you've got a counterclockwise torsion, you can feel this broad ligament stretched. And it's pretty obvious to work out which way the torsion's going, and then which way we're going to need to roll that uterus to correct it. In some preterm mares, it may be possible to GA her and use a plank to sort of hold the fetus in place while you roll the mare over and try and correct the torsion that way. But in my experience, mostly they end up on the surgery table, especially if they're close to term, and then a C-section can be performed at the same time. So prepubic tendon rupture is a fairly disastrous thing for the mare. The prepubic tendon is the tendon that attaches the large rectus abdominis muscles to the pelvis. So these sort of stretch from the sternum and the ribs all the way across the bottom of the abdomen and basically sort of furnish the abdominal floor. So if the tendon's ruptured, we've got nothing supporting the weight of the abdomen or that fold in there, apart from the skin. So yeah, it's obviously very painful for the mare. We get this dramatic change in her abdominal profile, and she will be quite depressed and reluctant to move. Long term for her, there's not much we can do to repair that. So generally we are focused on trying to keep her comfortable enough to get her to term, so we can manage an induction or a salvage cesarean and save the foal, hopefully. Another fairly unusual condition is hydrops. So this is, again, it is a life-threatening condition for the mare, but it does have a better prognosis. So we've got a rapid increase in abdominal size due to most commonly a massive increase in allantoic fluid. Again, you won't get that dropped profile, but you get the sort of barrel-like profile here. You get quite a lot of swelling under the ventral abdomen, and these mares will find it difficult to breathe because obviously the pressure in there is putting a lot of pressure on the lungs as well. So these foals are usually highly compromised or dead as when this is occurring. So the prognosis for saving a foal is usually very, very poor, but and therefore we know that intervention early is going to be the way we can save this mare, and not to concentrate on trying to do too much with the foal there. So once identified that this is the issue, the mare will need to be induced, and then we have to try and drain the fluid while supporting her with IV fluid therapy. Otherwise, she could go into shock. And surprisingly, the future breeding potential of these mares is actually quite good. So dystocia, I'm not going to go into too much detail because it's obviously, there's definitely enough scope for a talk on its own. So in horses, it's usually due to a malposture or a malpresentation. So instead of having a foal that's normally presented, so with its two front feet coming out first, followed by a muzzle at about the level of the knees, you're not being presented with those things. You're either, if it's a malpresentation where we might be presented with the rear of the foal, or a malposture, you might only be getting one leg up, or something along those lines. So obviously because stage 2 labour is so rapid, it's absolutely critical that that we get in and sort these out as soon as we can. So yeah, a simple problem like just having one leg back here, if left too long, will mean that foal is dead. So so prompt, so seeking prompt attention from the vet if you can't get the leg up yourself, or if you seem to have a normal presentation but you're not getting progression of that foal, then yeah, immediately assistance needs to be sought. Now, most dystocias will be able to be corrected in a standing mare or by GAing her. So we've got a bit more room to correct the malposture and push the foal back from the pelvis. But obviously, in certain cases of malpresentation, especially in things like these breech foals or dog sitters, then a cesarean is obviously going to be your best option. And if not, then maybe a phytotomy can be performed. So once the mare is foaled, conditions that occur in the immediate postpartum period include uterine prolapse. Now, these look pretty horrific, but they actually have a pretty good prognosis. Oh, sorry, let's go back. If they're attended to and replaced quickly. So we advise, if you are presented with this lovely red, angry looking uterus, that you hold the mare as steady as you can, support the weight of the uterus in a towel or something, and keep it as clean as you can until the vet arrives. Now these mares can be prone to shock, so they often require some sort of supportive treatment in that period after the uterus is returned to its proper position. It does have a good prognosis for survival and a pretty good prognosis for breeding as well. And surprisingly, these mares will often go back in foal during the same season. So periparturient hemorrhage, again, yeah, very serious condition, and absolutely life-threatening for the mare. You usually see hemorrhage immediately after foaling, but you can see it before foaling, during foaling, or even up to several days after foaling. Often it's those older mares that have had a number of foals. They'll present with colic symptoms. They're usually shaking, cold, have a very high heart rate, breathing up, and so if you suspect your mare is having a bleed after foaling, then you want to keep her as still and calm as possible. You don't want to be moving her anywhere until at least the vet has seen her, and if indeed the vet confirms that it is hemorrhage, then we don't recommend traveling her to a hospital facility. We recommend receiving supportive therapy on farm. By performing an ultrasound examination on the mare, we can usually distinguish whether it's rupture of a uterine artery, and so you've got a very severe amount of bleed and amount of hemorrhage within the abdomen, or a slightly less catastrophic broad ligament hematoma, and in that case the blood is confined to within the broad ligament. So yeah, our aim really when attending these mares to support the mare's cardiovascular system, because they're obviously hypovolemic, and so by giving them IV fluids, volume replacers, and even blood transfusions as well, while minimizing their discomfort. But essentially, we are relying on these mares to form a clot over that vessel, and they're not amenable to surgical repair. So uterine tears, these present in a fairly similar fashion to the hemorrhages. They are usually, it's usually sort of in that 24 hours after foaling that you'll see them presenting with some colic signs, depression. They may also be sort of shaky. Occasionally we do see eventration of the abdominal viscera, or be able to feel it when we're examining, when we're doing a vaginal examination. It's not always, uterine tears don't always occur after a difficult foaling. They can present after pretty normal foaling. If that foal has had a movement during the uterine contraction, they can quite easily put their foot through the wall of the uterus. So as I said, yeah, it's critical that the vet's able to distinguish between mares with hemorrhage and those that have a uterine tear, as the management is vastly different. These mares need to be transported pretty quickly to a hospital facility where they can receive a surgical repair on that tear, and also the intensive care that they're going to need for the ensuing peritonitis that they're going to get from having the contents of the uterus washed through into their abdomen. So the way that we do this in the field is just by performing an ultrasound examination of the abdomen. Often if it's blood in the abdomen, it can be fairly obvious due to the amount that there is and the sort of swirling nature of blood on the ultrasound scan. But if there's any doubt whether it's just increased peritoneal fluid or blood, then a peritoneal tap can be taken to confirm. So some trauma to the vestibule or the vulva is unavoidable at foaling, especially in maidens. So we classify these perineal lacerations by degree. So the first degree just involves the vulval lips, so the skin and the mucous membranes, and as you can see, repair is essentially a caslic, nice and easy. Second degree also involves the deeper perineal tissues and may impair the vestibulovulvar seal. So these are going to need a bit of rest before a more extensive repair is performed. And a third degree perineal laceration involves the vaginal roof, the deep perineal tissues, and the rectal floor. And this results from a foal that's been foaled with a foot nape posture, so it's got one of its legs over the top of its head, and it's managed to put its foot through the rectal wall, and then it's folded like that as well, so it's just essentially ripped right through the anus there as well. So similarly, these rectovaginal fistulas also caused by this foot nape posture, but the foaling attendant has realized what's happening and has been able to push the foot back through the rectal wall and fold normally, just leaving a hole in the floor of the rectum. So in both cases of third degree perineal lacerations and the rectovaginal fistulas, there's obviously marked contamination of the caudal reproductive tract. So although there's no immediate threat to the mare's life, she's obviously not able to be successfully bred unless these are repaired. The repair of both is best left for several months in order for swelling to resolve, and the maximum amount of sort of spontaneous healing to resolve. I have had a couple of rectovaginal fissures actually manage to heal themselves completely, but that's fairly uncommon. And then obviously when we take them in for surgery, as Angus was explaining with his Oviduct flashes, we again have them on a debulked and laxative diet, so that the feces are nice and soft, and we've got the best chance of our repair holding. So yeah, just on to retention of fetal membranes. So these should be passed within 3 hours of birth, and if they're retained for longer than 6 hours, then yeah, they can cause a number of problems. Doesn't make any difference whether the whole placenta is retained or only a small piece is retained. So that's why it's so critical to check the completeness of your placenta on delivery of the foal. It's usually this little end of this non-gravid horn that's retained. But if that's missed, then the next thing you're going to know is that mare is looking sick, off colour, she's got a temperature, and by that point she's going to have absorbed a lot of toxins from this essentially rotting bit of placenta left inside her, and then we're going to be, then the systemic infection is going to be well underway already. So if the whole placenta is retained, a ml of oxytocin should be given from 2 hours after foaling. That'll help the uterus contract and pass the membranes. If not, but if on those every hour and after 6 hours we still haven't passed the membranes, then veterinary attention should be sought for removal. Untreated mares can go on to have potentially fatal consequences, such as the development of a metritis, endotoxemic shock, and laminitis. So as we said, metritis is what can occur if retained fetal membranes aren't treated promptly, but it can also occur in mares that pass their membranes normally, and that may be due to a large degree of trauma in the reproductive tract following a dystocia, or it may just be because the mare's been maintained on box rest, so sort of any reason why there's delayed uterine clearance. So these mares will go off their feed. They have elevated temperatures, usually within 24 hours of foaling, and they require flushing of the uterus at least on a daily basis to remove that pool of toxins from the uterus. They need to be maintained on antibiotics, anti-inflammatories, and in severe cases, IV fluids and ice boots too. So yes, the final word: early recognition and prompt intervention is the key to healthy horses' good breeding prognosis and low vet bills. And this is me and my mare Treble last year when we were both at very late term, just hoping that we weren't going to encounter any of these issues. So thank you very much, Charmaine. And that's the end of my talk.
Thank you, Katie. I do love that photo. It's one that I've seen a few places. I think it's very cute and very appropriate given our. So where there has been a perineal rectal tear that has had surgical repair, what's the likelihood of the tear recurring in a subsequent foaling is our question.
Okay, well, depends on the repair really, and probably how extensive that tear was in the beginning. But most mares that I've had, dealings with have actually never had a problem again. I did have one mare a few years ago that had a very thin membrane. So it was, had a very thin membrane from the rectovaginal fistula. And that did pop again when she foaled the following year. So we had to then repair it again. I think, Angus, correct me if I'm wrong, but you're more likely to get problems with rectovaginal fistulas doing that rather than the third degrees. Because although the third degree is a more extensive operation, it's actually provides you can bring the two sides together much better, so you're unlikely to end up with one of these sort of thin membranes left.
We do, Angus has had to depart us, unfortunately, so he can't correct you if you were wrong. But I think that's obviously a good end to it.
Yeah, I mean, in my experience, mostly you don't get an issue, but if you do have, it's probably a slightly inadequate repair, then you may run into issues again.
Okay, great.
But most mares are actually maidens when they do this, so they go on to have good careers after that. So
and it's not then doesn't become an issue, I guess. I don't know if there's any other questions or answers or chats now. I think, Katie, that was, again, I love, like I said before, I absolutely love watching these because I think you go into such great depth, given the time frame that we have.
Maybe quite a bit too much.
No, it's one of those hard things, isn't it? But I think it's a great, obviously, starter on that. And I think, obviously, if anyone does have any questions, I know you and the team at Avenel are more than happy to get in touch. And we do have, we have a thank you here that's come through. I was so excited to get a question then. But Mia says, many thanks to the three presenters, Katie, Angus, Victoria, very informative. So that's good to know that we're on the right track there. Look, I would like to thank you, Katie, and your team ever so much for giving up this time. And I'd like to thank everyone who's attended or who is going to be watching this webinar in the future. I know a lot of people like to watch them in their own time because it can obviously be really hard to know where you'll be at any point in the season on night. And to all our attendees, I hope you found this session useful. As mentioned earlier, I would really like to thank, obviously, my colleagues in the other states, but I'd also like to thank Avenel, who we have worked with for some time now, and they've been great friends to us. And we really couldn't do this without them at all. So, Katie, I'd like to thank you very much.